Welcome to session 4 of Rio 2022. I'm Devi Nair from St. Bernard's Medical Center in Arkansas, US. In this session, we will be joining Julian Chun and Boris Schmidt from CCB Marcus Krankenhaus, Frankfurt, for a live case entitled Single-Shot Pulmonary Vein Isolation Using Novel RF Balloon, a New Golden Era. But before we join them, let's meet our panel. I have Dr. Andreas Metzner from Hamburg. Hello, Dr. Metzner.
Hi, good evening.
Dr. Vivek Reddy from New York. Hi, Vivek.
Hi, David. Hi, how are you?
Good. And Dr. Daniel Scher from Graz. How are you, Dr. Scher?
Good. Good to see you, Debbie.
Good to see you. So as with every session at Rio 2022, we are live. So we want you to get involved by submitting questions to us, and we will address as many of them as we can, and potentially maybe bring one or two of you delegates on screen to ask the questions live to the panel. So please do get involved. Without further delay, let's hand over to Boris and Julian.
Hello, everybody. Good morning, good evening, good night. Welcome to the second case from Frankfurt, CCB, and it is our greatest honor and pleasure to host the second single-shot device, if you want. And first of all, I would like to introduce the team who is actually working with us at 8 o'clock Central European time at night. And I'm very happy that Dr. Chao Ji Chen and also Dr. David Schaak are joining us. And of course, Mrs. Reda, you met her during the first case. She is swirling around, making sure the patient is fine. And we will present today, in the second case, RF balloon, the Heliostar balloon. And you will get to see all the details, merits, maybe demerits, and we will have plenty of time to discuss the case. I will hand over the word to Boris to introduce the case.
Hello from my side too. I'm very tired at 8 p.m., but I still keep on going. So today we are treating a 59-year-old lady with symptomatic paroxysmal atrial fibrillation. She hasn't had any membrane-active drug, so it's a first-line therapy for her. Her left atrial size is normal, as well as her left ventricular function, and her CHA2DS2-VASc score is 0, except for female gender, which would be 1 then. Maybe I just show you, Julian has already punctured the groin. We're doing 2 venous access.
You know what, I will just explain the setting, and then we go over the angiograms.
Okay, let's go.
And the one of you who already joined the first case may have realized we do follow a simplified strategy idea. Again, we had 2 punctures in the groin, 2 venous punctures. We have 1 catheter positioned in the coronary sinus. And in this case, because we have been waiting, we already performed the transeptal. And I'm now ready to introduce the steerable sheath, the GuideStar 14 French sheath, in order to then navigate throughout the left atrium. And we also, and we discussed that before, we do selective PV angiograms, and we did this again in this lady. And maybe Boris will have the chance to show to you in a second. In the meantime, I will exchange the sheath over the wire, which is parked in the left upper pulmonary vein. And this, maybe you can split the screen so we have, on the one hand, the fluoro, and on the other hand, the balloon. A camera onto the balloon, or on the, yeah.
Yeah.
Perfect.
Okay, so you're putting in the sheath. Could you please flush the balloon to with 25 cc per minute? So in my hand, I'm holding the Heliostar RF balloon. Could you inflate it, please? Is it? Yeah, now it's coming up. Okay, so you are hopefully able to see the balloon that is now inflating with a heparinized saline. It's an over-the-wire device. Again, in the central lumen, we have a navigated lasso catheter, the so-called LassoStar nav. Now, it comes in 15 and 20 millimeter, and I think also in 25 millimeter diameter. This one is a 15 millimeter diameter device. The balloon itself, can you inflate it to 35 maybe, so it's coming up a little more? We're increasing the irrigation, and what you can see is that it is covered with 10 golden electrodes extending from almost the tip of the catheter to, let's say, behind the equatorial line. The balloon, these electrodes actually are perforated with a laser such that you have irrigation fluid coming out of the electrodes to avoid coagulum and char formation. So irrigated RF ablation. In general, the balloon is a 28 millimeter device, and it's non-sizable, but by, let's say, varying the irrigation flow during the ablation, you can sort of change the compliance a little bit. And now it's fully inflated now. You see how the irrigation fluid is coming out of the electrode.
That is very impressive.
Okay, let's stop.
Boris, sorry, Boris. This is Vivek. Can I just make one comment, because you have such a beautiful image of the device. If you look at the polar region of the balloon, it is true that the distal, maybe centimeter circumferentially, is not ablative, right? Because the ablative element doesn't go that far. So I just wanted to point that out, because that means that when, let's say, for example, you're in a situation where the tip is right up against one side of the vein, as sometimes can happen on the left-sided veins, one has to be aware of that. So you have to make sure that the electrode itself engages the tissue. You know what I'm saying? Sometimes making the balloon a little smaller to get it in.
Absolutely right. So this is something to very much keep in mind. This RF balloon is not like a cry balloon. It's maybe more like the cry balloon, very, very first generation. The distal part will not be active.
Yeah.
All right.
It's important.
So then, shall we move on?
Boris, can I ask you a question about the lasso star nav? Is there a particular reason why you are picking the 15 millimeter?
Yeah, maybe we want to go through the angiograms, Devi, and then we can show you, and we will show it on the angiogram.
Yeah, so Julian did selective PV angiograms. Here is the LAO of the left superior vein. You see the left inferior vein here. And then LAO, you see the right superior and the LAO and the RAO, as well as the right inferior and the RAO view. So we felt that the vein size is rather small, less than 20 millimeters, and we felt that the 15 would be appropriately sized to record the potentials. And of course, we could have also tried the 20, but we reserve its use to larger veins in our experience.
So now we may also replay again, or you show the monitor B, in which we stored the baseline angiogram of the left upper pulmonary vein. And again, we do it like in a clockwise sequence, starting up left upper, left lower, right inferior, right upper. So this is our, let's say, established workflow. Now you see it here. You see the takeoff of the vein, and we will now come out. And now I would like to see the electrograms, please. Live screen electrograms. Perfect, you see it in the upper panel. And the first thing we will see, actually, we don't need fluoro for this. If the lasso star catheter is coming out, we would see, of course, electrograms. And this is, let's say, a very practical thing, which may help us to sort of reduce a little fluoroscopy and make sure we are in the correct position. So now we're diving deep into this left upper vein. We lost our potentials, as you could have seen. We don't mind at this point in time. And in the same time, we will try to collect a couple of points in a second. And I follow now with the balloon, as you can see in the fluoro, and have it here. So now we have the lasso star in the left upper vein. We have the balloon, which is sitting in the, let's say, ostial region. And we start collecting points in order to... And maybe we switch it to the Kato. Show it in the Kato, please. The Kato screen, perfect. So now you see already the reconstruction, very, very basic at this point in time, but you see the balloon, which is coming which is positioned here, and Boris is just by swiping around the lasso a little bit, we collect a couple of points, and we create a very, let's say, basic shell. All right, so we should be ready to inflate the balloon at this point in time. Can we inflate the balloon, please, with slow inflation?
Sorry.
25.
Sorry, Julian, can I ask one quick question?
Sure.
Did you guys put the catheter in there beforehand? Because I'm surprised that the electrical field was mapped so quickly, you know?
No. It was all live as the very first kiss and touch to the left side. The balloon was not in before.
But Vivek, have you worked with a navigated lasso star? Because that's a new
what it
feature.
is.
The very first generation had a non-navigated lasso star, and now it's a navigated catheter. That's why you can take points immediately.
Yeah, that makes sense. Okay.
Very important difference also with the updated version with the software, so we are able to inflate. Also, we call it a slow inflation instead of 35 with 25. So it allows to adjust the balloon a little and take an advantage of its compliance a little better. All right, so you see on the fluoro, we open it up a little bit, and we try to get in a good alignment along the vein. And now you see we have a very small spike. Maybe we can compensate. Yep, perfect. Work on this. Much better. So in order to understand our electrograms, you see PV1 to PV910. Those are the signals coming from the lasso star nav catheter, and underneath, these are the potentials from, we call it his 1,2 to his 910 from the balloon. So keep in mind, this device is recording a lot of, or giving us a lot of information from the vein, from the balloon, and also you can basically follow, in an ideal scenario, the activation of the vein, for instance. Okay, it's short runs. Okay, why don't we go for, an occlusion? All right,
Julian,
thank
are
you.
you mapping using the balloon as well, or just the lasso star?
No, for sophisticated mapping now, we don't take too much time, and we took the points using the lasso star nav feature. However, of course, you also could, in theory, use the balloon to take points and acquire points. So with this position and the occlusion, I am pretty happy. Die atmen gerade wieder nicht so gut. And I think we should consider.
Should we just focus the attention to the esophagus real quick?
Maybe we do one. Yeah.
Okay. So maybe what you can see in the LAO view now is the catheter sitting at the left superior PV, and the Circa probe is right behind. So we're very close to the esophagus, and we definitely need to pay attention to thermal injury, or to avoid thermal injury when we ablate. That's why we usually shut off 3 electrodes that face the posterior wall of the left atrium after 20 seconds of energy delivery. All other electrodes will deliver unipolar RF energy for 60 seconds. And that's why you can choose, in the CARTO, you could choose the electrodes 3, 4, and 5.
We just induced a fifth.
Those are facing the posterior wall, and those will be pre-selected and then terminate RF delivery after 20 seconds.
Okay, perfect. So why don't Xiaoji and David, maybe you showed in the live stream again the spike, what we believe is the spike, and we would like to understand its, let's say, response to the ablation. And maybe we can pace one more time from CS 1, 2, or 3, 4. Yeah, perfect. So we do pace a little more fast, probably. Okay, perfect. Thank you. And we store this. This is our, let's say, baseline sinus versus CS stimulation electrograms. And we talked now a while, and I think we should get ready for the first ablation. Maybe we check again on the temperatures. There's a lot of information basically from the device. We have the temperature, we have impedance, and we also cross-check with, let's say, local occlusion. And with temperature, we want to be around less than 31 degrees. Impedance, delta of 20 around, it's okay, it's acceptable. It's not perfect, but we will cross-check one more time with our local occlusion, and I think we should go for it, yeah. Go for an ablation. So focus, please. Now we have, unfortunately, a couple of artifacts. Now you see some delay, 8-9. Look at 8-9. Some more delay, gone. After 13 seconds, and maybe Xiaoji and David will show us the moment again, we isolated this left upper vein.
Can you show the temperature in the esophagus now?
Wonderful, thank you. Okay, 39 degrees. As Boris said, there's a close relationship, and we do monitor, and now
Shut
at
off
40,
two,
shut off.
Shut off 2 and 6.
The adjacent electrodes, we shut them off in order to avoid excessive heating. It's okay. So we do not have an additional rise, but you see, we have a reconnection. Now we have a reconnection of the vein. Okay, so let's cool it down a little bit.
Vivek,
Julian, do you
Yeah,
want to talk about the impedance change in that, just to talk about that in the bottom graph?
Yeah.
The impedance fall, I mean.
Impedance, delta impedance is a very, very helpful parameter typically. And we want to see a delta impedance of 2-digit numbers, we keep saying. So it should be more than 12 delta impedance drop, which was the case here in all those electrodes. Still, we have reconnection of this vein. Correct me, but it appears to be a fairly long delay between the far field and the PV spike. So my assumption would be that the roof part could be blocked.
I think you can nicely see it if you look at the heliostar electrograms.
Exactly.
So the heliostar electrograms show you that the conduction gap must be at heliostar electrode 1, 2.
Which is down.
Which is at the carina between the superior and inferior vein. And I guess that Julian now will move on to the left inferior to do a crosstalk maneuver. So ablate the left inferior, hit this part, and then isolate both veins simultaneously.
Sorry, first, would you guys mind? Sorry, could you mind showing that the impedance fall graph one more time? Because I thought what you just said is really
sure. Can you show
perfect.
the table again, Xiaoji?
Because if you look at electrodes 1
here
and
we have
2,
the statistics, and can we go on the big screen back? Yes, to the Kato, and you see on the right side the impedance delta, and you see 17, 13, and 1, 2 is 17 and 13, which are at least the lowest delta impedance compared to the others, also being a little bit in line with what we said before.
Right. So, Julian, I just want to point the bar graph on the bottom, because the bar graph,
I think that's a very important. That's a very important aspect. So, of course, we all know that RF energy works best when the contact is good. So. This is the only technology where you can have an assessment of contact to tissue before you start the ablation. So we will measure the impedance from each individual electrode as well as the temperature before we start the ablation. And there are given values that we should achieve before we start the ablation. And then, in addition to that, during the ablation, it's not only the time to isolation as a parameter for a durable lesion, but also we get local impedance values for each individual electrode, and we can see the impedance change to baseline values. And if we have a baseline, an impedance change of more than 12 or 15 ohms, we believe that this is a durable transmural local lesion. And I think that's a very good parameter to assess or to predict the durability of your lesions at each PV.
So
yeah, but I just
what
want
do we do now? What do we do now with our case here? We have this delay. We could think of taking advantage of the balloon going for segmental ablation, or going for, we call it a crosstalk phenomena, to isolate this part from the inferior section, from the inferior vein. And therefore, we review again the left inferior vein anatomy in the LAO, as you can see here. Okay? So there may be a chance, because of the close proximity or anatomic relationship, that we isolate this upper vein from the left inferior vein. I think we should move on and go for this. What do you think?
Right.
Good. So then we did deflate the balloon a little bit, and you may appreciate in the carto, you see there's a lot of numbers, a lot of figures, but you see also there's something which says inflation 0.5. This is the so-called inflation index. So now it's gone down to 50% instead of, we had 1.0 in the beginning. And now we know that we are ready to come back with the balloon into the sheath a little bit, keep our lasso out, and then going for this left inferior PV. And this was nicely shown also with the help of the carto, deep diving now into this left inferior PV. All right? And again, we lost our signals on the electrograms, or our electrograms from the PV, because we dive too deep into the vein. And then we call it, oops, a little out with the, yeah, okay, perfect.
How do you make sure you're not too deep in the vein and do a more osteal lesion versus an antral lesion? Are you based on fluoroscopy or angiograms?
Yeah, we know from the angiogram, of course, exactly where the takeover of the vein is, but also while on the flying throughout the atrium, we acquire more and more of the anatomy, and of course, and I mentioned this inflation index. If this inflation index, along with a very squeezed balloon, was low, of course, this is an indicator of a very deep position inside of the vein. So it's a combination of different factors which you should always keep in mind to avoid distal ablation inside the vein.
Can you inflate?
Okay, now we inflate again. You see the number is coming up, 0.6, 0.7, 0.8. 0.8 is good. Per definition, 0.8 would be okay. Now we jumped out with our CS. I don't mind. I put it up because we will paste the phrenic later on anyways. Okay, good.
So,
all right.
So Julian and Boris, this is Daniel. Could I just ask you to take us and also the audience who may not be fully aware of this excellent system on how you really assess for a good occlusion of the vein? I mean, is it obviously you get a lot of information with the system. Is it primarily the venogram you look at, or do you want all numbers to be in line, like the impedance and also the temperature? Or do you sometimes have to make a trade-off, like that one of the parameters is not perfect, and you still go for ablation?
Yeah, Daniel, thank you. Of course, it's real life. Sometimes, most of the times, you need to do some trade-offs. In ideal scenario, the delta or the impedance should be around 100 ohms with a baseline delta of 20 ohms. So this would be one thing which we sort of have in this case here. So we have pretty good contact. The temperatures from the temperature readings should be around a little less than 31 degrees, which is also okay. And then on top of that, we also have a look on the configuration of the balloon with the PV occlusion angiogram. So we invest 2 milliliter of dye. And we do it now. Okay. There was a tiny runoff. One more.
Maybe do a limbo.
Maybe we go back to the
inferior vein occluded. I'm going to go ahead with the first poll question. So the operators have prepared this poll question for our audience. We'll see how the results are. What appears to be the most attractive feature of the RF balloon?
So the
segmental ablation, energy titration, PV signal visualization, or short application time? please take a moment and answer the poll, and we'll come back to the answers later. We'll go back to the case again.
And while you are ready to vote, and we did something looking at the LAO now, we are more in a direct approach and really trying to compensate for what we discussed in the beginning. So we want to have good contact with the golden electrodes at all sides of the PV antrum. And this is therefore with the cryo, one could typically think of doing like a hockey stick, but this is not a cryo balloon. And this is why this is like something we called a limbo maneuver rather than a hockey stick. And we had a pretty good occlusion angiogram. So I think we should go for an ablation. And we defined posterior electrodes 4, 5, and 6. And let's have an eye again on the electrograms from the lasso. Start the ablation, please. And we have an eye on the temperature in the esophagus as well. Some artifacts. A little delay. Gone. 11 seconds, isolation.
Nice.
The limbo maneuver worked. After 20 seconds, per definition, we will shut off, and we do it now, the posterior electrodes, and now we have an increase. We shut off, please.
Shut off 7.
Yep. Okay, stop. All right, so you see the temperature came up a little bit. And here again, wow, good. So we need to ablate a little more, apparently. Now we look again into our signals from the balloon, and we see balloon 1, 2, 3, 4 may be interesting. And let's look into our table again also, and the delta impedance, please.
Julian, what's your features for the tags? Can you go over that a little bit?
The features for
your auto
We
tags.
didn't get your question, David.
Tags.
Oh,
that's a good question.
Yeah. So first of all, let me explain why we stopped the ablation. I don't know if you realize that the temperature in the esophagus went up to 42 degrees, despite the fact that we shut off five electrodes. That's why now we have resumed conduction, and we need to do a focal ablation, I guess. Coming back to the tags, those are depicting the impedance drop during the ablation. So dark red is more than or close to 30 ohms, and the lighter red are at 12 ohms. And we don't get tags if the impedance drop is less than 12 ohms.
Inflate again, please.
So yeah.
Slow inflation.
That's
let's move on a little bit. So we need to.
That's a preset we're working with, because we strongly believe that the local impedance drop predicts the quality of our lesions.
All right.
So we have. It's Andreas. May I ask another question?
Yeah. Hi,
just
Andreas.
a very quick one. Hi. Great procedure. Just a quick question. You had to stop premature while ablation of the superior PV as well as the inferior PV, some of the electrodes. Boris was introducing that you can adapt the size of the PV. It can be more compliant or less compliant. Would it make more sense to make it now less compliant, that you may be a little more distal, or more compliant to be a little more outside? Does it work?
Yeah, of course you can play with all dimensions, and this could be one option in theory. I think, however, still our goal at this point in time should be to ensure that we close the remaining gap. And I'm speaking about a gap because, again, we have a delay from the PV spike, and we have earliest activation in the lasso 5-6, and we had earliest activation on the balloon in the region 1-2 anterior inferior. So maybe we should again consider now as the next step to go for a segmental ablation. What do you think, guys?
Yes. Can you show the electrograms, please, for the audience? Yeah. That's what Julian said. You have a lot of information here. You have the information from the lasso star inside the tubular part of the vein, and the earliest activation there is probably 5-6. But you also have the electrograms from the heliostar electrodes, which are even more proximal, right? And we believe that the earliest activation here is anteriorly, 1, 2, 3, 4. So yeah, which electrodes would you like to ablate from?
Yeah, I think we should go for a semi-segmental approach, and we should go for 1, 2, 3, 4, 5, and 6. And we should maybe, we should turn off 6 after 20 seconds, again looking under the temperature.
Should we include 10? What do you think? 10?
Yeah, we can also go for 10.
Julian, I think we have the poll results back. So while you guys select your segmental electrodes, we'll share the poll results.
All right.
Können wir segmental
so it looks like the short application time, I think people are all about efficiency here. And segmental ablation, as you guys are going to show us very elegantly, is leading the poll here. Definitely some interest in the PV signal visualization and energy titration capabilities. I want to go ahead and just go on with the second poll question. So giving the audience a chance to answer that as well. Acquisition of a complete 3D LA map is essential for RF balloon PVI or is not essential for RF balloon PVI? Let's poll while we watch Julian and Boris continue with the case.
While you poll, we will start the next application, Devi, if you agree.
Absolutely.
Perfect. So let's
Julian,
ablate, guys.
Do you guys ever deviate the esophagus?
No, we don't do it. We don't deviate typically the esophagus. We have the temperature probe inside. That's it.
Gone. 13 seconds.
Vivek, I know you have quite a bit of experience with deviating the esophagus. What are your thoughts on high temperature rises like this in esophageal deviation?
Hinten ist alles gut, ne?
Yeah, we've sort of gone toward deviation in virtually all cases. So anytime we're using thermal ablation, we'll deviate the esophagus. So I would. So anyway, I think we all have different strategies to mitigate, and I have basically zero threshold for deviation.
Stop.
You know, one interesting question though, Boris, while Julian's ablating, maybe I can ask you. In the original software, we were not allowed to ablate with this balloon unless it was fully inflated. Are you allowed to ablate at lower inflation pressures now?
Yes, correct, Vivek. With the latest generation of the engine generator, now it's allowed to ablate with a 25 cc inflation speed, which gives you a little bit more compliance.
Because
balloon and
I remember when we couldn't
the procedure,
right? Because sometimes you have to make the balloon smaller so that you can get the tip of the electrodes to actually touch the tissue. Like when you have smaller veins, like the left inferior. You know, I wonder if that may have been part of the issue here. So I remember what we used to do, and I don't know if I'm allowed to say this, but we used to literally turn the stopcock part of the way so that as it decreased the inflation pressure, so you could get the tip of the electrode in there to do the ablations. Well, luckily you don't need to do that now, so that's good.
So Julian, here's another
friends
question.
From the panel, you may have noticed. Oh yeah, Daniel, you may have noticed though the vein, even though we had isolation after 13 seconds, again recovered. Wow, this is something very unique. We selected a nice case for Rio. Oh. That's a good one. But now we have to come up with another strategy to re-isolate this. And I would suggest we do something similar and also try to get a little different configuration with a balloon. This is what I would suggest. And Daniel, now I'm sorry to interrupt. Maybe you can comment and while we are working on this.
No. Just a quick question for the PFA, for those who use PFA, maybe in the audience, sometimes when in this case you have an anterior reconnection or struggle to isolate the anterior part of a vein, you may do an anterior twist with your hands, with the sheath, but I guess that's not something you do with this balloon technology, no? Or yes, Julian? I mean that you would clock the whole system a bit more towards the anterior side if you have an interior.
I'm sorry, I did not catch the full question.
Well, do you twist in this case the sheath and the system a bit more towards the anterior as you would do with the PFA with the Farapulse catheter, or do you just stay neutral in the vein and try to have good occlusion?
Yeah, It's a good point. Looking at the local impedance at baseline, it tells you pretty good where you probably have not too good contact. And on top of that, of course, the additional dye will confirm your thoughts on this. But of course, it is a good point. Once you realize you do not have good occlusion at certain regions, use your sheaths, you take advantage of the steerable sheaths, and also you can do like counterclock rotation in order to have a little more contact anterior if you need. Okay, so now here, again, we do something, and I would like and ask you to look at the fluoro. You may appreciate that now I curved the sheath and really did like a limbo dancer, the maneuver, in order to get even better contact to the anterior-inferior section with the full balloon. And we do one little dye injection again, while acknowledging the fact, look at the impedance, they are all pretty equally distributed around 100, so that's okay. One more time.
Does your transeptal site matter in these cases?
That's good.
1, 2, 3, 4, bitte.
So let's go for an ablation. Yeah, the transeptal site is also something which is, of course, of importance. We discussed that during the PFA case. In PFA cases, we allow a more central or even higher transeptal. With the Heliostar, I would try not to go too high and too up in order to get also proper contact. When contact with RF, is important, much more important than with PFA. Therefore, the right inferior vein requires a particular good contact. Therefore, I would avoid anterior and upper sites with this balloon.
It's interesting. If you look at the impedance fall on those green graphs, unfortunately, it's not falling very much. I mean, I'm glad it isolated, but you certainly worry about the quality of the lesion, huh?
Vivek, you have two fast eyes. We will see how it works out, yeah.
No, but it's correct, Vivek, and I think the reason is that in this particular case, the venous takeoff is at a very acute angle to the left atrial wall. And in those cases, with the cryoballoon, you would do a hockey stick maneuver and then a pull down. And with this, you need to find a way to bring the thick part of the electrode in contact with tissue. You should not only touch with the distal part, the narrow part of the electrode, to this acute angle, and therefore I think Julian is now doing something to push the balloon a little more inside the vein and to ablate inside just in a segmental fashion, just as if you would do it with a touch-up RF. Right? If you can't get from outside the Coumadin rich, you go in and then just ablate it there.
Yeah. I think that's the perfect thing to do, because I mean, to Daniel's question earlier, I think I always found it very difficult with this. Once you inflate, to actually try to maneuver the balloon with the sheath. You know what I mean? I think what you're doing now is perfect. Just a little less inflation, get it in, and then.
1, 2, 3, 4, applaudieren bitte.
Wir machen. Vorsicht. Wait.
And how much, Boris, is that LasoStar nav act like a good rail, or is it more just a mapping catheter? Or does it give you any support?
No, indeed, it is a good rail. So it gives you good support. It has good mechanical properties.
Nochmal ein bisschen dye, a little dye.
And it's only been with the first generation non-navigated lasso that we had to exchange it sometimes to a wire. But this one is really working well, I have to say.
Isolation, 8 seconds. Entrance exit block. So looking again into local impedance.
Yeah, the cartouche shows you that you're now a little closer to, or more distal, which is okay in terms of PV stenosis, but certainly better for the lesion durability, I'm sure. However, the impedance fall is not perfect.
But still also the feature of ablating segmentally shows or is shown by the fact that we don't observe any posterior electrode temperature or temperature rises in the esophagus because we shut off the posterior electrodes. So it works, this concept. We just need to durably isolate this vein.
Julian and Boris, obviously this is a tough case, which is a great case for a live case. But in your vast experience, what is the percentage of veins that will be isolated with the first application, as opposed to like this inferior vein now that is tough?
Yeah, we had certainly had a learning curve here. And there was also a technical learning curve. We talked already a little bit about the several iterations to the technology that we were working with.
Can you show the electrograms, please?
So
also?
with the latest version of catheter, engine generator, lasso star nav, the single shot isolation rate went up to 85%, which is a reasonable number. We usually only struggle with the left-sided veins and usually observe gaps at the Coumadin ridge.
We will see. We'll see what happens on the right side, guys. But still, the good news is the left inferior vein remains isolated, despite of, let's say, a pragmatic approach. You see, no more spike, and we also had activity running inside. And now we want to go ahead, but first of all, we also want to check what's going on with the upper vein, of course. And then we go inside again.
And there's a question from the audience.
Yeah, just note, please note. Look at this signal. Can you show it again?
Stenosis.
There was no more spike in the left upper vein. Now we are in the left upper vein, and we realize the concept of crosstalking, and it's isolated. So left side is done after a couple of work. And sorry, the question was about the risk for PV stenosis?
Yes.
Yes, sir.
Yeah. Based on our experience and also limited number of repeat procedures and also our clinical follow-ups, so far we have not observed any PV stenosis following this approach we are using in combining to understand the anatomy based on angiogram, local or the mapping information, and also balloon shape and positioning of the balloon at the PV. So therefore, at this point in time, all good. But still, of course, it's RF energy, and we know if you ablate too deep inside, unintentionally without knowing what you do, then there is always a risk. Okay,
also,
now we move on.
There's a question about vagal responses during left-sided, pulmonary vein ablations. Are you seeing any vagal responses with your experience?
Yeah, we also observed vagal responses, but it is not that, let's say, prominent as it is with electroporation with the Farapulse system, for instance. It's somewhat in the range we observed with the cryo balloon, for instance. So we get to see it, I would guess, in 15% of cases.
Inflate?
So now
Boris,
we moved over.
Any tips and tricks for common ostia, for left common ostia? Anything you would do differently or particularly pay attention to?
Yeah, well, I usually answer that patients with a left common with a short trunk, so early branching of the veins, we treat as if they were separate veins.
And pace it anterior from 7/8?
That is not a problem. Patients with a long common trunk, which is usually large, I think they are not ideal candidates for balloon ablation in general. Although Andreas and his group have shown that there's no difference in outcome with the cryoballoon, etc. But I still believe there are better ways in treating these patients. If you encounter such a patient and you have the technology in, you can do it. We did it. You have to do it in a segmental fashion. So do a lesion superiorly and one inferiorly and hope to connect the two lesions to each other. So to isolate the large common trunk with two separate lesions.
All right. So now we moved over to the right inferior vein. And here we have on the fluoro and on the carter, you see it's a very posterior takeoff from the vein. And we have at least some distance to the esophagus based on the fluoroscopic marker from the esophageal probe. Looking to the electrograms, maybe you show it again. We have the same pattern. We have the PV spike in the upper panel, and then we have the electrograms on the balloon. And I would say we try to give some dye, okay? That is acceptable.
Julian, do you ever try to paste off of the electrodes from the balloon to check for phrenic?
Exactly. This is exactly what I wanted to to share with you. And we did this. We paced from the anterior electrodes based on our map. And it's maybe we can repeat it again, Xiaoji. And let's pace again from the anterior electrode. Maybe you can, okay, you selected now 5, 6, you pace for it, and maybe the camera can look to my hand. Okay, if you can see it, we don't have capture. We don't have any phrenic nerve capture right here. We also may pace from the electrodes more up, Xiaoji, from the balloon 7, 8. Yep. So the anterior part of the balloon to search for potential phrenic nerve capture, which would be an indicator of a close anatomic relationship. Okay, no capture again. And now we pace from the CS, which is now already positioned inside the SVC. And here you may see, pace faster. You see the capture? Yeah, you can nicely see the capture we have here from the SVC side. Okay, very good. Now, the balloon is oriented or should be in a good alignment. Oh, wow. Stop the pace for a moment. Let's go over for RA one time.
Julian, while you guys position the balloon, I'm going to come back to the poll questions here.
Yeah.
We have answers for our poll.
Oh, it came off.
So the question was, do we need acquisition of a complete 3D LA map? And I think we are equally divided among our audience here. Half of our Rio crew thinks that we should, and half doesn't think we need one. What are your thoughts, Andreas?
Stop inflation.
Yeah, thanks for the question. So we also have some experience with this new tool, and I think 3D mapping gives a lot of additional opportunities. I think it's not very essential to have the anatomy, but it certainly gives some more additional information, how to guide the system, whether you're in good orientation and so on. You can easily see the electrodes because the system is shown within the 3D mapping system. So it offers additional aspects, additional opportunities to guide finally the system to the PV and into the PV and to find a good position.
So Andreas, if I may follow up on
let's actually go ahead and go on to our third poll question, and we'll let our audience answer the poll. My greatest safety concern using the RF balloon is phrenic nerve paralysis, PV stenosis, stroke, AE fistula. I don't have any concerns. So we'll have the audience poll while we watch Julian and Boris get the right-sided veins.
Yeah, Debbie, while you do the poll, we jumped into the right upper vein. And once we are there, we decided, okay, we go for ablation. I think we have only a couple of minutes left. Therefore, we wanted to show, of course, as much live as was possible. And again, spike activation on the balloon. And we will identify anterior electrode, Xiaoji, to pace for phrenics. Identify phrenic. Pace, please. From 7, 8, yes. And again, we have no capture here. That's good. That's good news. Perfect. Cross-check again, pacing from coronary sinus in the upper SVC. Now we have to configure it. Yeah, perfect. Here we have it. Frau Reda, wenn Sie da am Kopf mir freies Licht, grünes Licht geben. Perfect. Yeah, the lady, perfect. That's good. 0.8.
Posterior 1, 2, 3.
And we start ablation, please. Keep the pace.
Go.
No, not yet.
No.
Now it's gone.
You know, it's very
9 seconds.
It's actually very nice impedance drop if you look at those green bars falling. I mean, they were equal all the way across. I think that's the best positioning so far, right?
Julian, just another short and quick
You're right,
question.
Vivek. Yes.
If you would have capture from one of the electrodes, phrenic nerve capture, what would be the option? Would you make the balloon smaller, bigger? Would you turn it a little more? Or what are your options?
Oh, yeah, thank you. That's a very good question. The idea is to create a greater distance to the phrenic nerve, and therefore we would use a segmental stepwise approach, I would call it, and we would take off those electrodes in which we demonstrated capturing in order to close like a C, part of the circle. And then in the next step, we would use the lasso catheter as an anchor and move out to an anterior position with the balloon to create a greater distance to the phrenic, and then blade at this position in a segmental fashion. And this is a nice maneuver which helps to overcome that incidental finding of phrenic nerve capture.
Yeah.
All right,
Yeah,
so you see
perfect.
the right upper vein still isolated. Perfect. We now move down to the right inferior vein. And this is what we do now. We allow to deflate the device, pull it into the sheath back. Perfect.
Julian, like the cryo balloon, is there any concept for time to isolation with the RF balloon? Are you aiming for a certain time, or are you just looking for isolation?
It is, of course, it's obvious. The shorter, the better the effect should be. However, I have to say and state that the data is not that super clear at this point in time compared to what we know from the cryo. So it appears still. I think I'm sure it may also emerge as a promising parameter. Maybe not as good as impedance drops, but there's a certain value. But I think we still need to collect more data on this and also to standardize and synchronize workflows in order to have better experience on this. But it will be definitely a parameter to look into.
Inflate? But Andreas, you have some experience with that, right? One of your fellows looked into this analysis. Andreas?
I'm sorry, I didn't, thanks. I didn't hear a question.
Ilaria looked into the data and then looked for TTI as a predictor of isolation, if I remember.
Yes, it has. Yeah, it was predictive. I think isolation within the first 13 seconds was predictive for durable isolation during the procedure, at least. We do not have any data yet from any redo patients, but 13 seconds seem to be a good predictor.
Yeah, and Devi, for us, we have already done 6 repeat procedures after Heliostar index PVIs. So 24 veins, and out of the 24, 23 were isolated.
Okay. Again, posterior electrodes 10, 1, 2. Anterior electrode, we paste the CS. Phrenic nerve. Phrenic nerve. From CS, please, no capture. Yeah, now we have capture from CS again. And we start the ablation, right? Let's go, ablate.
Impedance drop is not too bad. Serious artifacts on the ECG. Difficult to assess, all right.
Temperature, esophagus unaffected. Phrenic nerve, nicely captured still. So, I still see something. I still see something in that. Okay, let's go, please, one more time to the REO and cross-check our alignment.
Julian, if you do not have a good impedance drop or say isolation, like in this case, do you just continue with the lesion and then just aim for another segmental approach later, since you are able to do segmental ablation?
Yeah, in theory, this could be, of course, an option. But as you have said, in this case, it was not too much change at all. So therefore, I was, and you may have noticed that the fossa is pretty floppy in this lady. And this is giving us a little less support. I think my first take would be to improve the, let's say, alignment to the vein and go for a different position. Maybe also going for a little deeper with the lasso.
Okay.
And try to
cannot
go in there.
It.
Okay. We jumped out again. No problem. So we deflate again, and we will re-enter. We will re-enter the vein, and then we go for a little deeper position. And you may have noticed in the baseline angiogram that the vein is pretty small. So it is. Einmal stop the inflation. Einmal deflate mode, please. Danke. So it takes a little while, a couple of seconds, to come down with the device.
Julian, are there any particular things that you do to avoid char and thrombus? And in the initial trials, there were issues with silent cerebral events. So are there specific setup that you have?
We, of course, keep high ACT levels, and golden electrodes, in theory, should be fairly, let's say, benign with regard to this. The full topic of silent emboli, of course, is multifactorial, I believe. In part, it is due to the energy and the source, energy source, but of course, it is also, let's say, infused or infected by workflow parameters like cardioversion, big sheaths, potentially angiograms, etc. So therefore, it is part of, let's say, of a left atrial procedure. In our preliminary experience, we do see a few also silent emboli, but it's in line with our, let's say, less than 20%, which we observed. It's asymptomatic lesions with cryo, with laser, or with conventional RF. So, okay.
Inflate?
Du hast es gerade ausgemacht.
What?
Shut up.
Oh, sorry.
Okay, inflate, please. We shut off the fluoro machine for a while. Okay, now we have accepted a little more, let's say, distal position with the lasso, and also the balloon is coming up now. Yep. 06. All right. 06.
That's good.
That's
I would
okay.
start.
Come on. Let's
Julian,
do it.
while you're positioning the balloon,
Yes.
I have a question for Andreas from the audience. And Daniel,
10-1-2
please,
is posterior and go.
jump in.
Pace the CS.
So if you have a tachycardia that is inducible post PVI, the question is, how would you target it? Would you use the balloon, or would you actually pull out something else? And I'll start with Andreas.
Yeah, it's a very good question. I mean, so far we did maybe 60 patients in total, and our main target is PVI, no question. And usually we do not pace after isolation of the PV, so we would not try to induce. If it would be a typical flutter, we would certainly take another catheter, go for the CTI. If the patient develops spontaneously any left atrial tachycardia, we would also take another catheter and go for linear lesion. But we never used the balloon for something different than only PVI. And but certainly we would do something in addition if we would have another kind of tachycardia, left atrial tachycardia. No question.
So I also
How
have
about
no
you,
experience outside the pulmonary veins. So maybe Vivek could also comment on that. But I know I'm fully aware that although the device is designed to isolate the pulmonary veins, there is experience. We all electrophysiologists, so we do stuff outside the box. And I'm well aware that the field has some experience on doing roof lines, inferior posterior lines, isolate the posterior wall, and other stuff, which at least in some cases, in some operators' hands, seems to be feasible. Of course, we have no study, no published data on that. Vivek, any experience from your side?
No, I completely agree. I think that I do think that with pulse field, and not even just the energy source, but the ability to alter device sort of conformation, ball, basket, and there are other device technologies with different approaches, that these issues will become a little less critical as you get to sort of, let's say, new generation single shot technologies. You know what I'm saying? They inherently seem to have a little more flexibility than sort of the balloon type thermal ablation devices we've had in the past.
Devi, Vivek, Andreas, Daniel.
Yes.
May we share what we have by now? We did this last ablation at the right inferior vein in a little more, let's say again, pronounced way. And we remapped now. And I show you the position of the lasso catheter now. And you see it in the electrograms. Please, can you show the electrograms again? This is the position, and the vein now is isolated. So even though it was, let's say, a little challenging, I have to admit, we were able to isolate all 4 veins within this 1 hour. I think you have seen a couple of real-life tips and tricks and obstacles you may run into, but also how to all together, looking at numbers, looking at green bars to isolate the vein. And so our procedure endpoint is obtained. So therefore, just wanted to summarize before the line will be cut off.
It's excellent.
Well, we're definitely running out of time for the session. I just want to thank Boris and Julian for this late night endeavor. Thank you very much for an elegant case and all your skill sets. And thank you again for our panel as well, Andreas, Vivek, and Daniel. Please join us in a few minutes for our next session. See you there. Thank you again.